5-alpha reductase deficiency is a genetic disorder in which a protein called 5-alpha reductase is defective or absent. 5-alpha reductase is an enzyme that converts the male hormone testosterone to its more potent form, called dihydrotestosterone. One of the most important roles of dihydrotestosterone is to help male external genitalia develop in a male fetus. Alright, so normally very early on in fetal life, male and female internal sex organs and external genitalia are undifferentiated and look identical. Within the first few months of development, testes develop in the male fetus. The testes start producing testosterone, which is a male steroid hormone that belongs to a class of hormones called androgens. The testosterone gets released into the blood, and a tiny fraction of it gets converted to dihydrotestosterone by 5-alpha reductase, which is mainly made in the skin of the genital area. Over time, dihydrotestosterone levels start rising, and it affects undifferentiated genital structures. Looking closely at these structures, at the top there's the genital tubercle, which is a small projection. Just below that there's the urethral groove, which is the external opening of the urogenital sinus, or the future urethra and bladder, and that's surrounded by the urethral folds and the labioscrotal swellings. Now, once dihydrotestosterone reaches these structures, it makes the genital tubercle elongate into a phallus, which will eventually be the penis. The elongating genital tubercle pulls up the urethral folds, which fuse in the midline, forming the spongy or penile urethra. The tips of the urethral folds remain unfused, and that forms the external urethral opening at the distal tip of the penis. The labioscrotal swellings also fuse proximally to form the scrotum, which eventually houses the testes. In females, the gonads develop into ovaries, which produce very low levels of androgens, so the genital tubercle remains small, forming the clitoris. And the urethral folds and labioscrotal swellings remain unfused or separate, and they surround the opening of the vagina. This process is usually complete by month 4 of fetal development. In 5-alpha reductase deficiency, there's a mutation in the gene SRD5A2, and that reduces the amount of 5-alpha reductase enzyme that's made. The condition is inherited in an autosomal recessive but sex-limited pattern. This means that for the disease to appear, both copies of the genes have to be mutated, and the individual has to be genetically male, with one X and one Y chromosome in each cell, since dihydrotestosterone has no role in the development of genetically female individuals, with two X chromosomes in each cell. So the problem arises in a male fetus where the testes produce testosterone, but it isn't converted to dihydrotestosterone because the 5-alpha reductase enzyme is missing. As a result, while there are male internal sex organs, the external genitalia follow more of a female path of development. Specifically, the phallus doesn't fully elongate, resembling something in between a clitoris and a penis, and the scrotum often remains split in two, which is also called a bifid scrotum, and the urethral opening remains on the underside of the penis, which is called hypospadias. The external genitalia doesn't look clearly male or female, and is sometimes called ambiguous genitalia. When these individuals reach puberty, though, there's a huge increase in the levels of testosterone. Even though it can't be converted to dihydrotestosterone, there's so much testosterone around that the phallus and scrotum grow larger, and start having more of a male appearance. In addition, the high levels of testosterone will usually lead to a deepening of the voice, muscle growth, and development of facial and body hair. Some individuals with 5-alpha reductase deficiency adopt a male gender role, while others adopt a female gender role. Most individuals with 5-alpha reductase deficiency also struggle with infertility. Diagnosis of 5-alpha reductase deficiency is usually suspected in newborns with ambiguous genitalia. A karyotype can be used to visualize the sex chromosomes X and Y, and ensure that the individual is genetically male. Lab studies usually show normal serum testosterone level and low dihydrotestosterone level, and therefore a high testosterone to dihydrotestosterone ratio. Treatment of 5-alpha reductase deficiency focuses on hormone replacement therapy. That means giving male or female sex hormones, according to the gender role adopted by the individual. Surgical procedures can also be done to help restore external genitalia to a non-ambiguous appearance. For those struggling with infertility, assisted reproduction techniques are useful too. Alright, as a quick recap, 5-alpha reductase deficiency results in a male fetus being unable to convert testosterone to its more active form, dihydrotestosterone. This leads to male internal organs and ambiguous external genitalia. Both sex hormones and surgery can be done to help align the external genitalia with the gender identity adopted by the individual.
Hey guys, thanks so much for watching. I hope you enjoyed the video and I hope we helped you learn something new about 5-alpha reductase deficiency. If you love our videos, don't be shy, share us with your friends on social media. And if you want to see more videos like this one, you can help support us by donating on Patreon, shopping at our Osmosis shop, or signing up for an Osmosis Prime account at osmosis.org where you can open up a whole world of studying tools outside of just videos. So definitely check those out. This video is brought to you by Antonia, who wrote the script, Rishi, who edited the script, Tanner, who did the voiceover, Marissa, who did the video editing, and I did the illustrating. Thanks again for watching. See you next time.
Androgen insensitivity syndrome is a genetic disorder in which a person with an XY genotype, genetically a male, is insensitive or doesn't respond to androgens, which are the male sex hormones. Androgens are responsible for primary sex characteristics, like development of a penis and testes, as well as secondary sex characteristics like height and body shape. So in androgen insensitivity syndrome, all of these can be affected. Alright, so normally, very early on in fetal life, male and female genital tissues are undifferentiated and look identical. During the 7th or 8th week, the fetal gonads develop either into testes or ovaries. In males, a gene on the Y chromosome called the sex-determining region Y gene, or SRY gene for short, helps the fetal gonads turn into the testes. By the end of week 8, the testes start producing androgens, the main one being testosterone. A small fraction of testosterone gets converted by the enzyme 5-alpha reductase into its more potent form, called dihydrotestosterone, which is mostly responsible for development of male external genitalia. Looking closely at these structures, at the top there's the genital tubercle, which is a small projection. Just below that there's the urethral groove, which is the external opening of the urogenital sinus, or the future urethra and bladder, and this is surrounded by the urethral folds and the labioscrotal swellings. Now, once dihydrotestosterone reaches the undifferentiated external genital structures, it makes the genital tubercle elongate into the phallus, that eventually becomes part of the penis. The elongating genital tubercle pulls up the urethral folds which fuse in the midline, forming the spongy or penile urethra. Only the tips of these folds remain unfused, to form the external urethral opening at the distal part of the penis. The labioscrotal swellings also grow toward each other and fuse medially to form the scrotum, which is the sac skin that contains the testes. Internally, the urogenital sinus is connected to a set of ducts, called Wolffian and Mullerian ducts. Testosterone also causes the Wolffian ducts to differentiate into the epididymis, vas deferens, and seminal vesicles. At the same time, the testes also produce a hormone called the anti-Mullerian hormone, which prevents the Mullerian ducts from developing into the female reproductive tract and instead makes them degenerate. About 2 months before birth, testosterone helps the testes descend from the abdomen into the future scrotum, and later on in puberty, testosterone helps sperm cells mature, a process called spermatogenesis. In females, there's no Y chromosome, so the SRY gene is absent. As a result, ovaries develop from the internal gonads, and androgen levels remain relatively low, so the genital tubercle remains small. And this forms the clitoris, and the urethral folds and labioscrotal swellings remain unfused or separate, forming inner and outer skin folds that surround the opening of the vagina, and these are called the labia minora and labia majora. Without the testes, anti-Mullerian hormone is also absent, so Mullerian ducts develop into the fallopian tubes, uterus, and upper part of the vagina. In androgen insensitivity syndrome, XY individuals have testes that produce androgens, but these hormones can't exert their action, because there's a defect in the androgen receptor on various target tissues like the external genitalia, genital ducts, and the testes itself. Androgen insensitivity can be complete, partial, or mild, depending on how well the androgen receptor is able to bind androgens. In complete androgen insensitivity, the receptor is totally non-functional, so the cells don't respond to androgens at all. As a result, the testes try to respond by increasing androgen synthesis. Without the effects of androgens, the testes sometimes don't descend into the scrotum, and instead remain in the abdomen or pelvis, which is called cryptorchidism. Cryptorchidism is related to a higher chance of developing testicular cancer later in life. In the absence of androgen influence, the epididymis, vas deferens, and seminal vesicles don't develop normally, and spermatogenesis is also affected, so sperm don't mature. Additionally, the absence of androgen influence means the external genitalia don't masculinize, and therefore they take on a female form, with a normal-looking clitoris, labia, and vaginal opening. In puberty, the excess testosterone is converted into estrogen, which is the primary female sex hormone, and this causes the development of normal female secondary sex characteristics, like breast growth, widening of the hips, and female fat distribution. Even though androgen influence is missing, the testes still produce anti-Mullerian hormone, and that means that these individuals don't have a uterus or fallopian tubes, and that their vagina ends in a blind pouch. So these individuals look like females, but they don't have menstrual cycles. In partial androgen insensitivity, there's some remaining function of the androgen receptor, so the cells and tissues are partially sensitive to the androgen effects. As a result, the appearance of the external genitalia and secondary sex characteristics varies widely, usually with a mix of masculine and feminine features. Finally, in mild androgen insensitivity, there's masculinization of external genitalia, but there may be some female secondary sex characteristics. In all three types of androgen insensitivity syndrome, individuals are usually infertile, since their testes can't produce mature sperm, and they have no ovaries or uterus. The androgen receptor gene is on the X chromosome, and androgen insensitivity syndrome is inherited in an X-linked recessive pattern. So in males, a single mutant gene causes the condition, and they can pass on the mutant gene to their daughters. Females with a single mutant gene are carriers, and they can pass the mutation to both their sons and their daughters. Androgen insensitivity syndrome can be diagnosed in infants with cryptorchidism. Alternatively, it can also remain undiagnosed until puberty, when an individual that has female genitalia doesn't start menstruation. A karyotype can be done to visualize the sex chromosomes to ensure that the individual is genetically male. In addition, serum testosterone and dihydrotestosterone levels are typically high. An ultrasound scan can be done to confirm the absence of the uterus and ovaries, or to locate the testes in the case of cryptorchidism. Treatment typically involves surgical removal of the testes, especially in the case of cryptorchidism, to help reduce the risk for cancer. Some individuals with androgen insensitivity syndrome adopt a female gender identity, whereas others adopt a male gender identity. Those that adopt a female gender identity can use estrogen supplements to help them develop a more feminized body. Those that adopt a male gender identity can use testosterone or dihydrotestosterone supplements, as well as surgery for external genitalia to help them develop a more masculinized body. Alright, as a quick recap, androgen insensitivity syndrome happens in XY individuals and is caused by a loss of function of the androgen receptor, which could be complete, partial, or mild, and affect the development of primary and secondary sex characteristics.
Puberty is the time in an individual's life when they physically become sexually mature and able to have children. Generally speaking, it's considered delayed if puberty hasn't started for a female by the age 13 and for a male by age 14. The hypothalamic pituitary gonadal axis is a system of hormonal signaling between the hypothalamus, pituitary gland, and gonads. The gonads are either the testes or the ovaries, and this will control sexual development and reproduction. Gonadotropin-releasing hormone is released into the hypophyseal portal system, which is a network of capillaries connecting the hypothalamus to the hypophysis, or pituitary. When gonadotropin-releasing hormone reaches the pituitary gland, it stimulates cells in the anterior pituitary, called gonadotrophs, to release gonadotropin hormones, luteinizing hormone and follicle-stimulating hormone, which then enter the blood. These gonadotropin hormones then stimulate the gonads to produce sex-specific hormones. These are estrogen and progesterone in females, and testosterone is the major sex-specific hormone in males. Early on in male development, testosterone helps the external sex organs to differentiate into male genitals and causes the testes to descend from the abdomen into the scrotal sac. Beginning at puberty, the Leydig cells of the testes respond to the luteinizing hormone by converting more cholesterol into testosterone. In addition, the Sertoli cells of the testes respond to follicle-stimulating hormone by producing more sperm. The major sex-specific hormones in women are estrogen and progesterone, and they are produced by the ovarian follicles that are scattered on the ovaries. Each ovarian follicle is made up of a ring of granulosa and theca cells surrounding a primary oocyte at its core. Beginning at puberty, theca cells respond to luteinizing hormone by producing androstenedione, an androgen. Then the granulosa cells respond to follicle-stimulating hormone by converting the androstenedione into estrogen and progesterone. Waves of estrogen and progesterone regulate monthly changes to the ovary stoma to promote egg maturation and ovulation, and as well it changes to the uterine wall lining as part of the menstrual cycle. The increased production of sex hormones drives the development of primary and secondary sex characteristics that we see during puberty. Primary sex characteristics refer to the genitals, which are the organs directly involved in sexual reproduction. Secondary sex characteristics refers to any sex-specific physical characteristic that is not directly involved or necessary in sexual reproduction, like pubic hair and breasts in females. The Tanner scale, or Tanner stages, is a predictable set of steps that males and females go through as they develop primary and secondary sex characteristics and become sexually mature. The Tanner scale centers on two independent criteria: the appearance of pubic hair in both sexes, and the increase in testicular volume and penile size and length in males, and breast development in females. There are 5 stages. In stage 1, the pre-pubertal stage, no pubic hair is present in either sex. Males have a small penis and testes. Females have a flat chest. In stage 2, pubic hair appears and there's a measurable enlargement of the testes and breast buds appear. In stage 3, pubic hair becomes coarser. The penis begins to enlarge in both size and length, and breast mounds form. In stage 4, pubic hair begins to cover the pubic area, the penis begins to widen, and breast enlargement continues to form something called mound-on-mound contour. In stage 5, pubic hair extends to the inner thigh, the penis and testes have enlarged to adult size, and the breast takes on an adult contour. Puberty is delayed if progression through the Tanner scale hasn't begun by the time 95% of an individual's peers have begun to sexually mature. Generally, that means puberty has not started by age 13 in females and age 14 in males. Hypogonadism, or lower levels of sex hormones from low gonad activity, is central to a delay in puberty. As a result, sex characteristics are underdeveloped. Permanent infertility can occur if puberty never begins or fails to complete and sexual maturity is never reached. There are two main causes of hypogonadism. The first is primary hypogonadism, which is caused by dysfunction of the gonads. For example, the gonads' receptors may not respond to gonadotropin hormones, or the gonads might not have healthy cells that are capable of producing hormone. Some acquired cases of primary hypogonadism are radiation therapy, chemotherapy, and trauma to the gonads. Some congenital causes of primary hypogonadism are genetic diseases like Klinefelter or Turner syndrome. Regardless of the cause, the result is a decrease or absence of testosterone in males or estrogen and progesterone in females, which means there's no negative feedback on the hypothalamus. This leads to an overproduction of luteinizing and follicle-stimulating hormones. So, primary hypogonadism is also called hypergonadotropic hypogonadism. The second cause of hypogonadism is secondary hypogonadism, which is also called hypogonadotropic hypogonadism, because there are low levels of luteinizing and follicle-stimulating hormones. Secondary hypogonadism can be due to hypothalamus or pituitary gland dysfunction, either from an inability to produce gonadotropin-releasing hormone, or luteinizing and follicle-stimulating hormones, or suppression from other hormones like prolactin or thyroid hormone. Some acquired cases are similar to primary hypogonadism: radiation therapy, chemotherapy, and trauma to the gonads. Other ones include a tumor of the pituitary gland and hypothalamus, and congenital causes include Kalman syndrome and panhypopituitarism, and general causes include chronic illness like cystic fibrosis or celiac disease, excessive exercise, malnutrition or obesity, and stress, all of which affect the way the hypothalamus and pituitary release hormones. A third category, called constitutional delay, is a temporary delay in puberty which does not typically result in infertility. Just like in secondary hypogonadism, there is a lack of gonadotropin-releasing hormone, but the key difference is that it's not considered pathologic. Instead, it's thought to be a naturally slowed rate of maturation. The onset of puberty can still occur naturally, and puberty can progress normally after onset. It just all happens at a later age. Typically, there's a genetic component to constitutional delays, and it runs in families. A delay in puberty is usually diagnosed by comparing an individual's sexual development with the Tanner scale. Blood tests of hormone levels can give an idea of the type of hypogonadism, and a detailed medical history, including evaluating any underlying medical conditions and family history for constitutional delay, can be helpful. The treatment for a delay in puberty depends on the cause. A constitutional delay can resolve on its own with the natural onset of puberty and does not typically require medical intervention. If an underlying medical condition is the cause, hormone therapy is necessary to ensure the onset and normal progression of puberty. Infertility treatments may also be needed to make reproduction possible. So to recap, delayed puberty usually means that it hasn't started for a female by age 13 and for a male by age 14. Though there are different causes which result in different levels of gonadotropin hormones, they all ultimately result in hypogonadism and a deficiency in testosterone or estrogen and progesterone. In contrast, a constitutional delay is when the onset of puberty might still occur naturally, with puberty progressing normally after onset, but it just occurs at a later age.
Kalman syndrome is an endocrine disorder caused by a decrease in sex hormones, either testosterone in males or estrogen and progesterone in females. That decrease leads to a failure to start or complete puberty. The syndrome is named after Dr. Franz Kalman, the geneticist who first described it. Normally, during fetal development, there's a region of the brain called the olfactory placode. Two groups of neurons emerge from that region. The first group contains olfactory neurons that eventually help with sensing smells. These neurons migrate from the olfactory placode and get embedded in the cribriform plate, which is a bone plate that separates the nasal cavity from the brain, forming the olfactory bulb. The second group contains neurons that release gonadotropin-releasing hormone, and these neurons migrate through the cribriform plate and settle in the hypothalamus. The hypothalamic pituitary gonadal axis is a system of hormone signalling between the hypothalamus, pituitary gland, and gonads, either the testes or the ovaries, to control sexual development and reproduction. Gonadotropin-releasing hormone is released into the hypophyseal portal system, which is a network of capillaries connecting the hypothalamus to the hypophysis, or pituitary. When gonadotropin-releasing hormone reaches the pituitary gland, it stimulates cells in the anterior pituitary, called gonadotrophs, to release gonadotropin hormones, luteinizing hormone and follicle-stimulating hormone, into the blood. These gonadotropin hormones then stimulate the gonads to produce sex-specific hormones. These are estrogen and progesterone in women and testosterone in men. Early on in male development, testosterone helps the external sex organs to differentiate into male genitals and causes the testes to descend from the abdomen into the scrotal sac. During puberty, the Leydig cells of the testes respond to the luteinizing hormone by converting more cholesterol into testosterone. The high levels of testosterone leads to the development of primary sex characteristics like penile and testicular growth. In addition, the Sertoli cells of the testes respond to follicle-stimulating hormone by producing more sperm. Increased testosterone also leads to the development of secondary sex characteristics, like growth of facial and pubic hair, increased height and muscle mass, and a deepening of the voice. In females, the theca cells respond to luteinizing hormone by producing progesterone and androstenedione. Then, follicle-stimulating hormone causes the granulosa cells to convert androstenedione into estrogen. During puberty, waves of estrogen and progesterone regulate primary sex characteristics, like monthly changes to the ovary stroma to promote egg maturation and ovulation, and changes to the uterine wall lining as part of the menstrual cycle. They also direct secondary sex characteristic development, like increased height and growth of pubic hair and breasts. In Kalman syndrome, there's a defect in the migration of neurons coming out of the olfactory placode. That includes the olfactory neurons, which can result in hyposmia, which is a reduced sense of smell, or anosmia, which is a complete loss of smell. It also includes gonadotropin-releasing hormone neurons, which results in a decrease in gonadotropin-releasing hormone. And that leads to low levels of gonadotropin hormones, luteinizing and follicle-stimulating hormone, and low levels of gonadal function. In males, there's a decrease in testosterone, and in females, there's a decrease in progesterone and estrogen. The disruption in hormones prevents puberty from beginning or successfully completing. Because of this, Kalman syndrome is a type of hypogonadotropic hypogonadism disorder. In Kalman syndrome, there's an underdevelopment of primary and secondary sex characteristics. In males, primary sex characteristic dysfunction includes having a small penis and testes, improper testicular descent, and a low sperm count. Secondary sex characteristic dysfunction includes a lack of facial hair, low muscle mass, and not developing a deep voice. In females, primary sex characteristic dysfunction includes amenorrhea, or absence of menstruation, or oligomenorrhea, or irregular menstruation. Secondary sex characteristic dysfunction includes a lack of breast development and pubic hair. For both males and females, Kalman syndrome often leads to infertility. Other non-reproductive symptoms include osteoporosis or osteopenia, because testosterone and estrogen are protective against bone resorption. A diagnosis of Kalman syndrome is made based on identifying low levels of gonadotropin-releasing hormone, low gonadotropins, LH and FSH, and low sex hormones, estrogen, progesterone, and testosterone, and this is all with normal levels of other pituitary hormones. Genetic tests for known gene mutations associated with Kalman syndrome can also be done. And finally, there's usually an abnormal smell test and sperm count as well. Treatment is focused on hormone therapy, which can stimulate puberty and the development of secondary sex characteristics. There's also infertility treatment, which can make reproduction possible in some cases. So, to recap, Kalman syndrome is a type of hypogonadotropic hypogonadism, where olfactory neurons and gonadotropin-releasing hormone neurons don't function normally. The decrease in sex hormones inhibits the development of primary and secondary sex characteristics during puberty. Hi everyone, Sarah here. Thanks for watching that video on Kalman syndrome. I hope you found it useful. The script was written by Amanda and it was edited by Rishi and Ifan. I did the illustration and the voiceover, and the whole thing was edited by Sam. So big thanks to the team who made this happen. We really hope you enjoyed it. If you did enjoy it and you've enjoyed other videos you've seen on the Osmosis YouTube channel, then what you need to do is head over to osmosis.org if you haven't already. Not only do we have more videos that aren't released on YouTube, but there are tons more resources which are super useful for medical school. It's just the perfect base for your learning, with questions, flashcards, and tips and tricks to organise your studies. So I definitely recommend that. As a past medical student myself and now a qualified doctor, it works. So enjoy, and head over to our Facebook page and leave us a review if you don't mind. And also interact with us on Twitter, Instagram and other social media platforms. And I look forward to creating the next video for you guys. Bye!
In polycystic ovary syndrome, poly means many, and cystic refers to cysts. So you might think that having many ovarian cysts is a crucial part of polycystic ovary syndrome. But while some people with polycystic ovarian syndrome do have ovarian cysts are no longer a necessary characteristic of the condition. Instead, polycystic ovarian syndrome is a dysfunction in the hypothalamic pituitary ovarian axis, which are the hormones that regulate the menstrual cycle. A normal menstrual cycle can be divided into two phases: the follicular phase, which takes place before ovulation, and the luteal phase, which takes place after ovulation. During the follicular phase, the hypothalamus secretes gonadotropin-releasing hormone, or GnRH. GnRH makes the anterior pituitary gland secrete two other hormones, called gonadotropins, in roughly equal amounts, which it releases in pulses. One of these gonadotropins is a luteinizing hormone, or LH. The other is a follicle-stimulating hormone, or FSH. LH and FSH travel to the follicles in the ovaries. The follicles are small clusters of theca and granulosa cells that protect the developing oocyte, or egg. The theca cells develop LH receptors which allow them to bind to LH, and in response, they secrete a hormone called androstenedione. Granulosa cells develop FSH receptors, which allow them to bind to FSH and produce an enzyme called aromatase, which converts the androstenedione to 17-beta estradiol, a member of the estrogen family. As follicles grow, the level of 17-beta estradiol in the blood increases, and it acts as a negative feedback signal. That is, it tells the pituitary to secrete less FSH. Less FSH in the blood means there's only enough to stimulate one follicle. The follicle that has the most FSH receptors grows the quickest and becomes the dominant follicle. At this point, about midway through the follicular phase, the granulosa cells also begin to develop LH receptors. As that happens, the dominant follicle keeps secreting estrogen, and the rising estrogen levels make the pituitary more sensitive to the pulsatile action of GnRH from the hypothalamus. Blood estrogen levels start to climb, and now the estrogen from the dominant follicle becomes a positive feedback signal. That is, it makes the pituitary secrete a whole lot of FSH and LH in response to GnRH. This happens a day or two before ovulation, and the massive surge of FSH and LH binds to the granulosa and theca cells, which help facilitate rupture of the ovarian follicle and release of the oocyte. While the rest of the theca and granulosa cells degenerate and die off, a now fully matured oocyte breaks away from the dominant follicle and pops out of the ovary. The egg begins its journey down the fallopian tube to the uterus, and the luteal phase begins. Now, while polycystic ovarian syndrome affects the whole menstrual cycle, it really starts with a breakdown in this follicular phase. In polycystic ovarian syndrome, the anterior pituitary makes too much LH, at least double the amount as FSH. Excessive LH causes the theca cells to produce excess amounts of androstenedione, way too much for those granulosa cells to convert. The excess androstenedione flows into the blood, and some of it gets converted into estrone by aromatase in fat or adipose tissue. Estrone, like estradiol, is a member of the estrogen family, stopping the anterior pituitary from releasing FSH. Because LH levels are really high, there's no LH surge to trigger the dominant follicle to break away from the ovary, so it may remain there, appearing as a cyst, or it may degenerate with the other follicles. The bottom line is that ovulation doesn't occur. Now, what causes the anterior pituitary to make so much LH is not well understood. But because the majority of those with polycystic ovarian syndrome have insulin resistance, it's thought that insulin resistance somehow disrupts the menstrual cycle. Insulin resistance happens when the cells in your liver, adipose tissue, and muscles become insensitive to insulin, and the cells become less willing to pull in glucose from the bloodstream, and this can develop into diabetes mellitus. Not one to give up, the persistent pancreas secretes more and more insulin until it can get those cells' attention. As a consequence, some people develop hyperinsulinemia, or too much insulin in the blood. Theca cells have insulin receptors, so excess insulin can bind to the theca cells, causing them to grow and divide, and over time, that means having too many LH receptors. It's thought that the hypothalamus responds by speeding up its pulses of GnRH so that more LH is made by the pituitary. High levels of androstenedione from polycystic ovary syndrome can cause hirsutism, or hair growth on the chin and upper lip, chest, and back. It can also lead to male pattern baldness, meaning a thinning of the hair starting from the crown of the head, as well as acne on the face, chest, and back. Lack of ovulation causes amenorrhea, meaning an absence of menstruation, or oligomenorrhea, meaning infrequent and irregular menstrual periods, both of which can lead to infertility. Those with insulin resistance may be overweight or obese, and may develop acanthosis nigricans, which are dark velvety patches in the creases of the neck, groin, and underarms. A diagnosis of polycystic ovarian syndrome typically is made when there's a high ratio of luteinizing hormone to follicle-stimulating hormone, as well as high levels of androstenedione in the blood. A pelvic ultrasound may reveal follicles on one or both ovaries that look like small cysts, but these aren't necessary for the diagnosis. Weight loss, especially by eating foods with a low glycemic index, can help reduce insulin resistance and can help improve the symptoms of polycystic ovary syndrome. Metformin can also increase insulin sensitivity. Spironolactone can be used to treat hirsutism, but because it's teratogenic, some form of contraception is required. Oral contraceptives can also help regulate the menstrual cycle. Clomiphene citrate can help induce ovulation. A procedure called ovarian drilling, which involves puncturing a cystic ovary, can induce ovulation, though it's not recommended for everyone because it can damage the ovary, and it doesn't resolve the overall hormonal imbalance. Alright, as a quick recap, polycystic ovary syndrome is marked with symptoms related to excess androgen production, like hirsutism, acne, insulin resistance, and irregular or absent menstrual cycle. Polycystic ovary syndrome is associated with an overproduction of the luteinizing hormone by the pituitary gland, and also with insulin resistance.
Puberty is the time in an individual's life when they physically become sexually mature and able to have children. Precocious refers to puberty occurring at an earlier age than the average age among an individual's peers. Generally, puberty is considered precocious if it begins before the age of 8 in females and the age of 9 in males. The hypothalamic pituitary gonadal axis is a system of hormone signaling between the hypothalamus, pituitary gland, and gonads, either the testes or ovaries, to control sexual development and reproduction. Gonadotropin-releasing hormone is released by the hypothalamus into the hypophyseal portal system, which is a network of capillaries connecting the hypothalamus to the hypophysis, or the pituitary. When gonadotropin-releasing hormone reaches the pituitary gland, it stimulates cells in the anterior pituitary, called gonadotrophs, to release gonadotropin hormones, luteinizing hormone and follicle-stimulating hormone, into the blood. These gonadotropin hormones then stimulate the gonads to produce specific steroids, sex hormones. Beginning at puberty, the Leydig cells of the testes respond to the luteinizing hormone by converting more cholesterol into testosterone. In addition, the Sertoli cells of the testes respond to follicle-stimulating hormone by producing more sperm. The major sex-specific hormones in women are estrogen and progesterone, and they are produced by the ovarian follicles that are scattered on the ovaries. Each ovarian follicle is made up of a ring of granulosa and theca cells surrounding a primary oocyte at its core. Beginning at puberty, theca cells respond to luteinizing hormone by producing androstenedione, an androgen. Then, the granulosa cells respond to follicle-stimulating hormone by converting the androstenedione into estrogen and progesterone. Waves of estrogen and progesterone regulate monthly changes to the ovary stroma to promote egg maturation and ovulation, and changes to the uterine wall lining as part of the menstrual cycle. The increased production of sex hormones drives the development of primary and secondary sex characteristics observed during puberty. Primary sex characteristics refers to the genitals, organs directly involved in sexual reproduction. Secondary sex characteristics refers to any sex-specific physical characteristic that is not directly involved or necessary in sexual reproduction, like pubic hair and breasts in females. The Tanner scale, or Tanner stages, is a predictable set of steps that males and females go through as they develop primary and secondary sex characteristics and become sexually mature. The Tanner scale centers on two independent criteria: the appearance of pubic hair in both sexes and the increase in testicular volume and penile size and length in males and breast development in females. There are 5 stages. In stage 1, the prepubertal stage, no pubic hair is present in either sex. Males have a small penis and testes. Females have a flat chest. In stage 2, pubic hair appears. There is a measurable enlargement of the testes, and breast buds appear. In stage 3, pubic hair becomes coarser, the penis begins to enlarge in both size and length, and breast mounds form. In stage 4, pubic hair begins to cover the pubic area. The penis begins to widen, and breast enlargement continues to form a mound-on-mound contour of the breast. In stage 5, pubic hair extends to the inner thigh, the penis and testes have enlarged to adult size, and the breast takes on an adult contour. Precocious puberty is when a child starts progressing through the Tanner scale before 95% of other children that age. Generally, that means that puberty has started before the age of 8 in females and 9 in males. Precocious puberty is usually due to a central or peripheral problem. Central precocious puberty, or gonadotropin-dependent precocious puberty, results from early maturation of the hypothalamic pituitary gonadal axis. When that happens, it causes an early release of luteinizing hormone and follicle-stimulating hormone, which in turn causes an increase in sex hormones. Ultimately, early maturation of the hypothalamic pituitary gonadal axis could be due to a dysfunctional hypothalamus or pituitary gland. One cause could be a tumor that's releasing gonadotropin-releasing hormones, or human chorionic gonadotropin, a placental hormone that's similar to luteinizing hormone. Another cause is an infection or cyst or radiation damage to the brain that impairs the negative feedback system in the hypothalamic pituitary gonadal axis. But most of the time, there's no identifiable pathology, and it's simply called idiopathic precocious puberty. Idiopathic precocious puberty is considered a normal variation in the age at which puberty begins, and is influenced by factors like when a parent began puberty as well as an individual's weight. The other category, peripheral precocious puberty, or gonadotropin-independent precocious puberty, is the result of the abnormal overproduction of sex hormones by the testes or ovaries. This could be caused by an ovarian or testicular cyst or tumor, genetic conditions like McCune-Albright syndrome, dysfunction of other glands like the thyroid or adrenal gland, or exogenous sex hormones from medications and creams. The key feature of precocious puberty is early sexual maturation, and it often causes a lot of emotional distress because children can feel social pressures that come along with sexual maturity. Precocious puberty is diagnosed using the Tanner scale. Gonadotropin hormone levels can help distinguish gonadotropin-dependent or independent causes, and medical imaging by ultrasound or MRI can be used to look for structural abnormalities in the brain and gonads. Treatment for pathologic causes of central precocious puberty typically involves using gonadotropin-releasing hormone analogs, which can suppress the hypothalamic pituitary gonadal axis hormones. They work by binding to the gonadotropin-releasing hormone receptor on the pituitary gland and decreasing the release of luteinizing hormone and follicle-stimulating hormone. That ultimately reduces the levels of sex hormones and slows puberty. Treatment for peripheral precocious puberty depends on the cause. In some cases, surgery is needed to remove a tumor or cyst from the ovaries or testicles. Alright, as a quick recap, precocious puberty means that puberty has started early, typically before the age of 8 in females and before the age of 9 in males. It's usually identified using Tanner staging. Oftentimes there's no underlying pathology and it's considered a normal variation called idiopathic precocious puberty. If there is an underlying pathology, it's typically due to central or peripheral causes that ultimately result in early release of the sex hormones, which leads to early sexual development.
In premature ovarian failure, which is also called primary ovarian insufficiency, the ovaries stop functioning normally, and this means that they stop ovulating or releasing egg cells. And they also stop producing hormones, mainly estrogen and progesterone, and this all happens before a woman is 40 years old. It's considered a primary problem because the problem is with the ovaries themselves, rather than the glands or the hormones that act on the ovaries. Normally, the hypothalamus, which is located at the base of the brain, secretes gonadotropin-releasing hormone, or GnRH. GnRH makes the nearby pituitary gland secrete two hormones of its own, called gonadotropins. These are follicle-stimulating hormone, or FSH, and luteinizing hormone, or LH. These hormones travel to the follicles within the ovaries. The follicles are small clusters of granulosa and theca cells that protect the developing egg. FSH acts on the granulosa cells, making the follicles grow and mature as well as secrete estrogen, while LH stimulates the theca cells to secrete progesterone and small amounts of androstenedione, which is a precursor to testosterone. All three of these hormones belong to the class of steroids, or lipid-soluble hormones. At birth, a woman has millions of follicles, each ready and excited to do its job. During puberty, the monthly menstrual and ovarian cycles begin, which is when the endometrium, or inner lining of the uterus, goes through cyclic changes in response to the ovarian hormones. During the ovarian cycle, the ovarian hormones also help a handful of follicles to start growing. Eventually, there's ovulation, which is when a single follicle fully matures and ruptures, releasing its egg cell, while the other follicles degenerate and die off. Over time, many ovarian follicles degenerate, and the ones that remain become less and less sensitive to gonadotropin stimulation. This goes on until menopause, when there are no remaining follicles responding to gonadotropins, and that causes menstruation and ovulation to cease entirely. In most women, this occurs between the age of 40 and 60. Now, in premature ovarian failure, the follicles stop responding to gonadotropin stimulation earlier than usual, that being before the age of 40. In the majority of cases, there's no clear cause. In some cases, it's linked to chromosomal abnormalities, like Turner syndrome, where an X chromosome is missing. Other times it can be gene mutations, like BRCA1, or in a syndrome like Fragile X syndrome, which is caused by the expansion of a trinucleotide repeat within a gene on the X chromosome. In other cases, the ovaries can get harmed by chemo or radiotherapy, or by an autoimmune destruction process where the immune system goes rogue and attacks the ovaries. There are two proposed mechanisms that could explain how premature ovarian failure develops. The first mechanism is that there are few or no remaining follicles in the ovary, and this could be because the ovaries started out with only a few, or because a lot of them degenerated too quickly. The second mechanism is that the follicles are dysfunctional, meaning that they're present but simply can't do their normal job, either because they can't generate gonadotropins themselves, or because they don't respond to the gonadotropins, or because they can't generate hormones themselves. In any case, the ovaries fail to respond to pituitary LH and FSH, which means that they don't release egg cells normally and produce less estrogen, progesterone, and androstenedione. However, about half of these women maintain some intermittent ovarian function. In premature ovarian failure, when estrogen levels are low, the pituitary gland attempts to restore balance by increasing production of gonadotropins, LH and FSH. However, the follicles don't respond, so there are still low levels of estrogen. This is called hypergonadotropic, because the level of gonadotropins is high, hypogonadism, because the level of gonadal or ovarian hormones is low. Some symptoms of premature ovarian failure are directly related to the absence of ovulation and the low levels of estrogen and progesterone. Most women have a normal puberty with regular periods before the disorder develops, but then start having troubles when premature ovarian failure occurs. Absence of ovulation causes missed or infrequent menstrual periods, and it also causes difficulty conceiving or infertility. The lack of hormones can cause hot flashes, night sweats, and vaginal dryness, which can lead to dyspareunia or pain during sex. Estrogen normally has a protective effect on the cardiovascular system, helping to keep the blood vessel walls flexible to accommodate blood flow, as well as the skeleton, where it helps to sustain bone density. So, low levels of estrogen can also lead to complications like cardiovascular disease and osteoporosis, or decreased bone density. In general, the symptoms mimic natural menopause, but unlike menopause, some women are still able to spontaneously get pregnant because they have intermittent ovarian function. Diagnosis of premature ovarian failure can be done by detecting low levels of ovarian hormones, mainly estrogen, and increased levels of LH and FSH. Additionally, a karyotype can be done to look for chromosomal abnormalities, and specific genetic tests can be ordered if there's a family history of Fragile X syndrome. If autoimmune causes are suspected, testing for steroid cell antibodies, or STCAs, which react to adrenal cortex cells can be done. That's because there's a similarity between ovarian cells and the cells of the adrenal cortex. The main goal of treatment is to replace the hormones that the ovaries have stopped producing, especially estrogen and progesterone. For women who struggle with infertility, in vitro fertilization can be used. Eggs are taken from a donor, fertilized, and then implanted into the hormonally prepared uterus of a woman with premature ovarian failure. Alright, so as a quick recap, premature ovarian failure occurs before age 40 and is caused by not having enough follicles in the ovaries, or having follicles that don't respond to gonadotropins. The result is that the ovaries fail to respond to pituitary LH and FSH, which means that they don't ovulate or release egg cells normally, and they produce less estrogen, progesterone, and androstenedione. This can lead to symptoms that mimic menopause, but some women with intermittent ovarian function are still able to get spontaneously pregnant. Hi everyone, Sarah here. Thank you for watching. That was my second ever video, premature ovarian failure. So I'd love to hear what you've got to say about it. So if you can pop some feedback in the comments, that would be great. That script was written by Antonia and edited by Rishi, and I did the illustration, the voiceover and the editing. Thank you again for watching. And if you like that video and other videos that are on the Osmosis YouTube channel, make sure you head over to osmosis.org where there are tons more videos and a lot of them aren't actually released on YouTube. There's also questions and flashcards and a whole bunch of resources which are super useful for medical school. Also check out our Facebook page, our Twitter and our Instagram and anything you can find just to give us a bit of feedback because we love that. And I look forward to making the next video for you. Thanks, bye!